Thank you for inviting me to be a part of this clinical controversy. So we just heard a great presentation about sentinel node alone in these patients, and what I'm hoping I can do is convince you is that there's a better way, and that's by adding the clip in the node. Just to get back to my key arguments that I want to tell you is that evaluating the clipped node in addition to the sentinel nodes is a more accurate way to assess axillary response after chemotherapy. And my second argument is that residual small volume disease in the axilla has prognostic and therapeutic implications, so that accuracy is really important for us. To bring us back to basics, how this all started with ACOSOG Z1071. There was a subset of patients, 170 patients, who had a clip placed in a lymph node when biopsy confirmed disease. And if that clipped node was retrieved as a sentinel node, the false negative rate dropped substantially. It makes sense. If you want to know if chemotherapy got rid of the cancer in the lymph nodes, you should look at the lymph node that you knew had cancer to begin with. So this is a logical step in axillary staging. So this led to the development of targeted axillary dissection, and what that means is removing the lymph node with known disease, so that lymph node that you put the clip in at the time of biopsy, as well as the lymph nodes that are most likely to have disease, or the sentinel nodes, and the addition of all of those is targeted axillary dissection. So I know that a lot of you agree with me because we did a survey of the American Society of Breast Surgeons, and we asked them what is important for minimally invasive evaluation of the axilla after chemotherapy. And 82% of the breast surgeons said placing a clip in that biopsied node and ensuring removal was critical to the accuracy. Why is that? Well, the clipped node is not a sentinel node in a fairly high proportion of patients. So here's some of the trials that have been coming out. We have more and more data showing this. In our initial data, 23% of the cases, the clipped node was not retrieved as a sentinel node. We now have CENTA, which was 50 institutions in Germany. It was a prospective registry trial. 37% of cases, the clipped node was not a sentinel node. And in RISIS, which was also a multi-institutional trial in the Netherlands, 29%. So if you looked at only the sentinel nodes in those cases, you would not be looking at the lymph node that you knew had cancer to begin with. And we see this in the results of false negative rates. So here are those three trials. You see the false negative rate of sentinel node alone. It gets lower when we look at the clip node alone, but when we add both of those, we have very low false negative rates, and this is in all three trials. So I think in my mind, it's very clear the most accurate way to assess nodal response is to place the clip and add that to sentinel node dissection. But the question is, so what? So we've heard some great data that more surgery might not matter, but I would argue that knowing if there is residual disease can be very important. This was a trial from Sloan Kettering where they looked at even very small amounts of disease found in sentinel nodes after chemotherapy. And what they found was even if you found a very small amount of disease, there was likely more disease in the axilla. So if you missed it, you would have been missing actually a pretty substantial amount of disease. And even if more surgery isn't important, and I think Alliance 11202 will tell us this, we have lots of controversies in many forums in this week, including this forum, talking about adjuvant therapy when there is residual disease after neoadjuvant chemotherapy. So if we're really going to say that adjuvant disease matters, it's very important that we are accurate in assessing whether a patient has residual disease or not. Future questions, to some of the points that Dr. Galimberti pointed out, can we place the localizing clip at the time of biopsy so we spare some of the expense and some of the procedures? Does additional surgery impact outcomes? And is a TAD appropriate for patients with extensive nodal disease? And actually, CENTA 2 is now being rolled out where they're enrolling those patients to take a look at that question. So in summary, I think evaluating the clip node in addition to sentinel nodes is the most accurate assessment of nodal disease. And then small volume disease has prognostic and therapeutic implications that we can't ignore, and we really rely on the accuracy of that assessment. Thank you.
All right, this isn't a polling question. Show of hands, no clip. Okay. Clip. Ooh, okay. A lot of true believers out there. Thank you. So you guys, that was a fabulous presentation.